tuberosity, sir, and the gap is about 3 centimeters. So we have done an end-to-end anastomosis using Krakow technique.
What is the gap?
3 centimeters, sir.
3 centimeters. Both
centimeters.
in flexion, dorsiflexion, plantar flexion, or
No, sir.
only radiology,
In
ultrasound, ultrasound.
In USG it has given us partial tear, but in once opening it is complete tear. He is difficult in walking, sir. He has a. No, sir. No, sir. No, sir.
So what is the difference between tear and rupture?
Tear is usually in young adults, sir. Severe trauma will be there. Rupture is usually seen in old patients of degenerative changes. Complete, yes, sir. Complete.
Some of the fibers will be intact.
Yes, sir.
Tear is partial. Rupture means complete. There is
Complete.
nothing like partial.
Yes, sir.
So most of the time seen in elderly people, repetitive farmers and all those things. Those people are working every day. They are going to the fields working. So degenerative ruptures also there, traumatic ruptures are there, sports injuries are there. All are different.
Yes, sir.
66 years old female, intracapsular fracture of left femur. It is transcervical type. We have done bipolar hemiarthroplasty with bone cement, sir. 66 years.
66? 66. So is it a
Increased, sir. Lesser trochanter.
See this, compare this. This is at the level of the ischial tuberosity, not at the tip of the tuberosity.
Yes.
Here it is almost here. It should have been here. The stem length appears to be, the neck length of the prosthesis appears to be too long. Probably a little calcar is supposed to have been removed. That would have made the limb lengths equal.
Yes.
See, the top of the greater trochanter is falling to the center of the head of the femur.
Yes.
Here, where is it falling? It is falling over the neck. Was the reduction easy or tight?
Easy.
Hmm?
Reduction is easy.
Was easy. This is going to cause early erosion into the acetabulum because of the length is increased.
Yes.
And there will be undue stretching of the muscles attached here, abductors, and there will be undue stress and there will be early wear off of the acetabular cartilage. This is how you should look at the post-operative X-ray, not just looking at not only at the position of the stem. Femoral head offset is a very important factor. Vertical offset and horizontal offset. Have you looked into that? Did you read all these findings when you have looked at the post-op X-ray? We don't care much about that. Yes.
72 years old male with closed distal third both bone fracture of right forearm, sir. We have done open reduction, internal fixation with plating for radius and ulna, sir. For radius, Henry's approach, sir. We gone through between brachioradialis and radial artery. And Ellis plate, sir. Ellis plate, it can't do the distal and radius.
The distal fragment in the radius is too sharp, it doesn't have a good purchase with the regular
DCP, yes, sir.
It hardly will have only
2 screws.
Hardly.
Yes, sir.
So you have got a better purchase, both horizontal as well as vertical. Next.
for all practical purposes, the both
Intra-articular.
Considered as intra-articular fracture. What do you mean by intra-articular fractures?
Anatomical reduction.
Swami, what do you mean by intracapsular fractures?
Intra-articular.
Intra-articular. What do you mean by intra-articular fracture? How do you plan for intra-articular fracture management?
Anatomical reduction, rigid fixation.
Reduction number 1 point, excellent, 30 marks.
Rigid fixation.
Rigid fixation. Oh. Anything else?
Stable concept.
Vinay,
Stable concept.
out. Any one more point? Anatomical reduction, articular congruity. Anatomical reduction, articular congruity, stable fixation. There should be no angulation. There should be no displacement.
Anatomic reduction
That
also
means everything.
indicates that everything has been
Include. I know mali cheptunna, so that you don't forget. So there should be no displacement, no angulation, no rotations. That should be there. And articular congruity. We have to see that articular surface will be well maintained.
Yeah.
So this is the case of implant removal.
point. Why is it called as intraarticular fracture for forearm?
Yes.
60.
That point is left wing.
Yes. Why? Both bones forearm fracture should be treated like
Articular fracture.
intra-articular fracture. But how? How do you say it's intra-articular fracture? How many joints are there in forearm?
3, sir.
How many joints are there in forearm?
3.
Superior radioulnar,
Superior
radioulnar,
radioulnar,
interosseous. So interosseous joint is also called as the third joint. So you have to take care of the third joint also. Not only flexion extension. So names are in here.
60 years old female, 1.5-year-old post-op status of intertrochanteric fracture with implant in situ. DHS. We have done implant removals.
How many years fracture? 4 years, huh?
1.5 years.
This is a 36-year-old male, sir, with subtrochanteric fracture of left femur. This is a syncytial type 3A, sir. We had an ORF with long PFN for left femur, sir, with saccage wiring. This is a 45-year-old female with intertrochanteric fracture of right femur, sir. This is body different type 2. We had an CRF with PFN, sir.
Ideally, short PFN, long PFN, that's what there is. General clerk.
Sir.
PFN is given better results because there is a high chance of stress resor effect, peri-implant fractures, rehabilitation delay, so on and so forth.
This is sir, 14-year-old boy, sir, with closed middle third shaft fracture of left forearm, both bone shaft fracture, sir. So we have gone for a close reduction with a TENS for ulnar and radius. That's it, sir.
Good morning, sir. This case done under Unit 2. 5-year male, closed supracondylar fracture of right humerus with no DNVD. We have done open detection internal fixation with KR fixations.
The first X-ray before the slab.
Sir, after slab, we have taken X-rays.
Was not available.
No, sir. No, sir.
It was there. I remember you have seen it. Why no reduction has pain?
Sir, we tried.
Done under anesthesia.
Sir, we tried, but reduction was.
Done under anesthesia.
Yes, sir.
Not at all. You have reduced better under anesthesia. Is that improper manipulation?
What is Tom's line? What is McLaurin's line? What is its importance? Radius voltage.
5 years.
Was it closed reduction or open?
Open, sir.
Good morning, sir. 50 ml with intertrochanteric fracture of the right femur. It is Boyd and Griffin type 2 displaced. We have done closed reduction internal fixation with proximal femoral lines.
Your journal club is on short PF and long PF.
No.
Whose journal is on that?
Nisar. Nisaruddin.
Nisar. Where is Nisaruddin? Present absent. Brother. We advise short or long? Long. Why so?
68 years old female with intertrochanteric fracture of right femur, sir. Borden Griffin type 2. We have done closed reduction internal fixation with PFS. 39 years old male with 1 week old disfranc injury left foot, sir. Hardcastle and Meyerson classification type B2. Medial column TMT joint congruity is maintained, whereas middle and lateral column TMT joint congruity is displaced. We have done open reduction with K-wire fix. B2, sir. B2, type B2, sir. Yes. Yes, sir. Medial column was intact, sir. Middle and lateral column were displaced, so it is type B2. But intra B1, middle and lateral column should be intact, sir. This is B1, and medium column will be displaced, sir.
It is totally congruous or totally incongruous?
C is divergent displacement. Okay, sir. In type 1, there will be total incongruity of all T1. Hardcastle and Meyerson classifications. Meyerson and Hardcastle classification. Yes.
This is the pointer. Give me your mouse. This is the pointer.
On this. Type 1 is
Pointer ఉంది కదా? You got the pointer. Electric charge pointer.
in type A, there will be total incongruity of all 5 TMT joints, sir, and they are divided into further two tests based upon direction of displacement. A is lateral and A2 is dorsoplanar. Whereas in type B, there will be partial incongruity. That is, out of 3 columns, either 2 columns will be intact. In B1, medial most column there will be incongruity and there will be medial displacement. Whereas in B2, there will be lateral displacements of middle and lateral columns. Whereas in type C, these are known as divergent dislocation, and based upon their congruity, they are divided into C1 and C2. In C1, there will be partial incongruity. There will be divergent displacement of 2 columns, whereas rest of lateral column will be, 1 column will be intact. Whereas in C2, there will be divergent dislocation of all TMT joints.
So your medial column is intact.
Yes, sir. But intra we saw there was subluxation of medial column as well, sir. So we have fixed with KY for medial column. B2, B1 is medial displacement. B2 is lateral. Our case have lateral displacement.
And no divergence.
No, sir.
No?
No, sir.
It appears that there is a medial cuneiform.
Fracture is medial cuneiform fracture.
Fracture on
Is this not a medial column? Medial column. Cuneiform is fractured.
Yes, sir.
And how did you say it is a B? B2.
Sir? Hardcastle and Meyerson class. Meyerson and Hardcastle classification. Sir? Yes, sir. Yes, sir. This is the case. Divergent.
Divergent. Along with that,
There will be
right.
fractured base of fifth metatarsus.
That is, I mean, given already. Classification is there.
No, sir. Regarding combination, it is not described in classification.
But anyway, this is a, I think it's unclassified, but belongs to list ranks only. What?
What is Kuni and Kush classification?
It is classified into three types: homolateral, isolateral, and divergent.
Comes under
Diverge. Divergent.
homolateral,
Isolated and divergent.
divergent, and comes in which classification?
Divergent is. We have done open reduction and internal fixation with K-wire, sir. Once we have fixed medial and middle column, lateral column was also reduced. But since there was
But
combination
on
at
the
the
day
base.
of, I mean, the admission, who has seen this patient?
Sir?
Who has seen the patient first? No. Was there a compartment syndrome?
There was impending compartment.
Is there foot compartment syndrome or not?
If it is there, what are you supposed to do if it is a compartment syndrome? You want to release or not?
Fasciotomy.
Fasciotomy, how many inches you want to give? Same inch you have to give now. The things you have done now, the same have been done on the same day.
No.
That's what to avoid to avoid the complications further. And did you see the dorsalis pedis artery?
The distal pulses were intact. Yes.
Intact. Dorsalis pedis.
Chusan.
Was there a difference? Ankle brachial difference is there. You know what ankle and brachial are? Ratio.
Is it possible to palpate?
Hmm.
Is there a abdomen?
Oh, yes.
Hematoma.
Edema is there. It's very difficult to palpate.
We were able to palpate and we
You
felt
are able to
it was-
palpate
Yeah,
of your own pulsation, I think. Not
we felt
bad.
it.
Anyway,
Peripheral circulation
yes.
is a very good indicator. If you pinprick the toe, if it bleeds briskly, with
That's
right
okay.
ventricular,
Right.
this is an adequately oxygenated because you don't feel the pulse there.
Oh, is the angle restored here? Intermetatarsal angle. Angle, yes?
Yes, sir.
Right.
Is it necessary to put K-wires into the second and third one also? If you push the lateral most fifth metatarsal into position, all the other will fall back into position, supposed to. Is it necessary to put K-wires?
It was loose. Complete. I was being there. Complete has gone outside. With man patients come inside, right?
You have to justify your answer. There will be questions raised. You should be able to justify. One K-wire in the fifth metatarsal is not going to make it absolutely stable. It can still be very unstable. That is why you need to fix it. That is how you should answer it. Huh? Yes.
This comes under the Lisfranc fracture dislocation.
Okay.
This Franks means
List-
always dislocation only.
No, not one, all. Not only one. All can be described in this list, right?
55 years. Sir.
Dislocate stable or unstable?
Unstable. 55 years old female with 6 weeks old Lisfranc injury of left foot, sir.
Today is this
This is
Fresh one.
6 weeks old.
6 months.
1.5
months.
No problem.
6
This
weeks old. Instead of putting 1.5
6 months old.
ideal would be 6 weeks. Because we are our minds are trained like that.
One. We count months, not the years.
If it is so many months, then months. If it is less than 3 months, weeks would be a better understanding. Yes.
it comes
Type
under
A.
classification. Sir?
Type A.
No, sir.
Middle also is involved.
Comes no. Divergent
Is it a
and
fresh one or old one?
old case. Sir.
Means 6 weeks.
Yes.
So
6
do you think it's a Wrist fracture to be operated or just can leave it like that, put a cast and make it more.
Since it's unstable, it's divergent fracture.
Okay.
Divergent
You
fracture.
can see the Lisfranc fracture also, that's the ligament.
Metatarsal also is involved. It is not at the joint but at the base.
Yes.
Yes.
That is the difference.
What else is there? X-ray? Anything you are seeing which is, what is it?
Accessory navigation.
After saying so many times. Right.
When you are encountering with a case of an injury, it is not only for the fracture that you should look at,
Other
you
things.
should look at like a radiologist. They will search all corners of the film and try to report it. Any classification for navicular? Excellent. Okay. Next case.
So what have you decided to do that? What's the plan to treat that? The patient only pain is a problem or unable to walk? What is the problem patient has come?
She had constant pain while walking, sir.
Okay. That's
Any even slightest incongruity
And
in the
also-
foot bones, including the metatarsal and tarsal, there will be lot of difficulty. Unlike in metacarpal fractures where some disability can be acceptable, but not in the foot because it is a weight-bearing joint. Yes.
And also,
Foot is more complicated than hand. Mechanics of the foot.
yes.
What is the mechanism of injury? First one
she,
and second one.
for first one, he was a pillion rider. History of RTS. This one, for this case, she had a history of slip and fall.
Pillion rider, what happens? Suppose sitting back, you'll get a fracture here. If
No,
your foot is on the
get-
footrest on the right side, someone coming from opposite side, if it hits again, then differently later fracture like dysfrancs. That's what the mechanism is.
The leg will be externally rotated, and the medial border of the foot is the one that is exposed to the
Yes.
Direct.
oncoming vehicle. That is why it gets dislocated later.
Otherwise, any other mechanism of fracture for this?
Axial compression on a plantar flexed foot.
Yes. Where do you get?
Also.
Athletes, football players,
Sports.
all these things I get.
Any violence that gets transmitted from medial to lateral.
For this case, we have done.
Why?
She already underwent a history of repeated massages and.
So, but depending on the radiology, then you can decide or what?
Yes, depending upon.
Straight away
There
go
are
for
also
orthodosis.
arthritic changes as well, sir.
So what have you fused
We
here?
can't get
You refuse the first joint. That's all.
First TMT joint.
Other how many joints are normal?
Congruent.
If you fuse one joint in the ankle,
Rest
other
of
joints
them
will cry. So all will have osteoarthritis of some time. So be careful about this. You have to follow this for a long time. One joint is orthodox, other joints are there. They'll also cry for that. They'll get osteoarthritis. That should be there.
What is the indication of orthodosis in this case? What is the indication?
Post-
Where do you advise orthodosis? Orthodosis is there, osteosynthesis is there, osteotomy is there, excision arthroplasty is there,
Post-traumatic arthritis.
replacements are there.
Post-traumatic arthritis.
Post-traumatic. How many months old?
6 weeks.
6 weeks old.
6 weeks. 6 weeks is post-traumatic arthritis.
It might progress into.
Yes, sir. 6 weeks post-traumatic arthritis.
Depends on what the patient has undergone.
All the fracture involving the uniform metatarsal joint.
Yes. Fracture was involved.
Intraarticular.
Yes.
That is the one.
So it is a mid-tarsal. Mid-tarsal involvement.
Yes.
How many bones are there in mid-tarsal? How many bones are there in mid-tarsal? 5 ఉంటాయి. What are the 5?
3 cuneiform clavicular.
3 cuneiform. This all comes on mid-tarsal.
9-year male with grade 2 distal and fracture of the left femur.
So you got a Lisfranc line. You have got a Lisfranc line and you got a Chopart line. Both are different. In between you have got a mid-tarsals. That's the point. This is right.
9-year male with grade 2 distal and distal and fracture of the left femur. The mode of injury is he fell from the bike. Distal femur fracture.
Is it open fracture?
Yes, sir.
Bones are continued with
Not
the
grade
then?
2, sir.
Oh no. Is the
It is in the lateral, sir. Posterior lateral.
posterior lateral?
Which side is the knee? Which side you should include one, at least
Yes, sir.
one joint above and joint below. Otherwise, we don't know it's upper arm or thigh or what forearm.
Sir.
Are the bones coming out? The wound?
No, sir.
No,
Lateral.
not seen.
No.
Did you palpate?
Yes, sir.
No connection to the bone at all.
First we.
Closed fracture.
Yes, sir.
Open
Closed and open, yes, sir, but not exposed.
Technical.
Bony fragments were not exposed.
Open only technically.
Technically, yes. Technically compound.
Invariably, because the distal femur is almost subcutaneous, especially in a thin fellow, must have been in direct communication. Because it's angulated, the sharp fragment must have penetrated.
9 years old, right?
9 years.
So why do you want to put plate for this?
We try to reduce it with KVS initial. First we
Did you
reduced
open it or
Yes, sir.
did you open completely the fracture site?
Yes, sir. We opened it and
Same
reduced
side?
with KVS. Yeah.
Same side of the wound you have seen explode or other side?
Other side, sir.
Not medial side.
In
I
middle
said
side,
put
yes, sir.
only
That-
cross fin and enough. Show me first X-ray.
But
Show the first X-ray, right? Just above this.
If you are afraid of an internal fixation, put a next fix. Fracture steel.
Or you can easily put, sir, cross fin and
Otherwise,
that's better.
you are crossing the growth plate, and there will be premature
growth restriction.
The-
not arrest. It will be slowed down
Temporary slowdown, right?
post-op X-ray.
What I advise was only cross pinning, sir. It's about there.
We avoid the 5/6 plates, 5/6 line. We passed one screw at the epiphyseal region and two more at the.
Why into the epiphysis?
Length you wanted. Otherwise,
The
no need.
distal end of the plate might get diverted,
Correct, but
so for better contact and to the.
Why do you want to do it?
9-year-old boy, the vascularity of the bone will be very good. They heal very fast, provided there is no infection at the fracture site. And now the medial column is left open. The lateral column is under compression. If you leave it for,
Angulation there.
if you leave it for 12 weeks, not 1 year, then you will come with a valgus deformity.
No, here growth cartilage is not touched, sir. Nothing happens. Into the intrafacial. Right.
It will not allow it to grow.
If you put something in the.
It is something like
right.
a transient
Yeah,
episode.
right. Ah. That's all. The growth cartilage which is there, we are not seeing it all. That inside the F5 you are doing it, nothing happens here. Unless it. That's what growth may not affect.
Theoretically
Yeah, yeah.
speaking, it is supposed to maintain the distance between the distal most and the second screw from the bottom. Then it will not be allowed to grow. just
It
like
gets
on the
compressed.
medial
That's
column.
what. It will compressing over the growth cartilage. That's the problem. You'll have to remove it immediately.
What does the figure of 8 plate do? Figure of 8 for growth modulation. FPCOD. What does it do? You know what is a figure of 8 plate?
లేదా కుదిసినట్లేదా
No idea. That is a fixation device
మీరు ఇట్ నాట్ హిండర్ ది గ్రోత్
for transient FPCODC, which is temporary. After
That's
the
what.
desired result have been achieved,
దేకో
then the plate would be removed. It is something like that. The second and the
Concept.
third screw from bottom probably would have been adequate.
అదే మేబీ ప్లేస్ వాజ్ నాట్ దేర్ పుట్ వన్ మోర్ ఇన్సైడ్ రైట్
Need not have been put.
బట్ యు హావ్ టు టేక్ ఇమిడియట్లీ ఆఫ్ 6 weeks I mean 6 months
The moment you find callus, you can remove it.
ideal
Have to remove it.
yeah
not can.
ideal was to do only cross pinning opening
Yes, because it has got
yeah you
adequate
can
purchase.
yeah that's what
The length of the distal fragment
yeah
from the fracture site to the growth plate is adequate for to arrest
don't
it.
hold that
And it need not be absolutely anatomic reduction.
And in open fracture children, so you can wait for some time with the X-fix, directly going for fixation.
Ideal would have been
X-fix,
an X-fix,
X-fix,
because you are not going to open it, further strip it. Just do debridement, put an X-fix. For a short period, you could have put a spanning. For a better
Even you'll not is enough, sir. You'll not, that's just
two pins would be enough.
but enough.
It is required only till the soft tissues heal. Maybe which will heal in about 4 weeks or
3 weeks.
Such cases we used to put what's pins and plaster. 2 pins above, 2 pins below, and corporate plaster. That holds it. Ideal.
16-year male with closed middle third shaft fracture of the right femur. It is Wingfist and Hansen type 3, sir. More than 50% of the width of the femur is involved. We have done close reduction, internal fixation with interlocking nails.
16 years.
Yeah.
Right.
The mode of injury is he fell from
No,
height.
maybe first X-ray. What about the trochanter?
It's
GT
not
is closed.
It's not yet closed, sir.
Why? So what to do here? That closed was 19 years, no? For 16 years you have injured the base piriform fossa now.
We tried, we avoided it, sir. Like
How?
almost.
How did,
we
where is the entry point there?
as medial as possible
then
It is an interlocking nail. It has to go through
Yes.
only
through the
Piriform.
piriform fossa. Yeah, but
or tip of the trochanter, yes, special plates are there or special, rods are there, but not available here. But we have injured that now.
What is the build of the boy?
it's medium builds,
Moderate
moderate builds, sir.
or thin?
Shadow.
Moderate build.
All right. So what complication gets? Suppose you put the nail now, patient will come out from about 1 year. What do you expect?
If the trochanter might, if the trochanter is involved or get damaged, we can.
You're not done anything with trochanter, no? You're going to piriform fossa only. The circulation is lost there. Every chance of getting a avian is there
Avian.
in future.
Vascular.
Right.
On the table,
Sir.
we have found out that there is a significant gap between the two fractures.
First we need to fix the. First we need to fix the proximal screws. Then we can do thumping from the distal end, or else we can fix the distal screws, and with the jig.
Only one.
Only one. It is not hard. However, when you can beam which కొట్టినా అది కలదు పైకి వెళ్ళదు కింద నుంచి కొడితే.
We can fix the distal screws.
Fix the distal one.
We can, and with the zig we can pull it,
And then with the extractor on, you have to
pull it up.
pull it.
44-year male with a closed surgical neck fracture of right humerus. Needs classification. Two. Part. Only head shaft, greater trochanter and lesser trochanter.
What about clavicle? Clavicle is normal.
No, sir.
3 months ముందు
Is the fracture clavicle or not?
The old fractures, 3 months.
Old fracture.
3
Old,
months.
Not what is fresh one.
old
No,
fracture.
old fractures.
So how do you know?
He
No pain there, no swelling there now.
No, sir.
right now no.
Medial side.
Fresh fracture.
Surgical.
The ribs are fractured.
Contralateral.
The medial end
Ends.
almost near the sternum.
That must have gone already.
You have been having a very heavy impact, likely to be associated with rib injury.
Rib fractures.
No hemopneumothorax.
No, sir.
Age, what is the age? Age,
44 years.
44.
We have done fillosplating.
All neck fractures, fillosplating only. The other method is there to fix it. Show the first X-ray. Or can you treat the K-wires from above?
It is
Yes.
very well
So-
impacted. It is an impacted abduction fracture. If it is varus, it will be
Yes.
unstable. It is in valgus. impacted abduction. Varus type of fractures will be always unstable. Even if you reduce it, it may not get retained. Here it is an impacted one. It is an acceptable position or a satisfactory position.
If the
Cuff and collar is going
yeah,
to be
if the option is given to the patient, select a conservative or operative. He says, conservative only. What do you do? Some patients may not agree for surgery. So what plan you do? Three choices are there. Is it hanging cast or Velpu bandage or just a sling? All three can be used. Hanging cast can be used. Velpu bandage can be used or just a sling. That's enough.
shoulder immobilization
Yeah.
for 3 weeks.
That's enough. Okay.
It becomes sticky in 3 weeks.
Pratidyan surgery అవసరం లే. Everything you want to do, nothing else.
Sir, 40 years male with closed middle third shaft fracture of left tibia and closed fracture of neck of left fibula with no DNVD. We have done closed accidental fixation with the ILN for tibias.
"27-year male with left acromioclavicular joint disruption. He has sustained an injury 6 months back while he was hit by a bike from backside, sir.
Backside.
Yeah. So in the clinical images, we can see step off at the lateral end of the clavicle, and also superior migration of the
Lateral end.
lateral ends of the
That
clavicle.
means is the counter of the shoulder normal?
Loss, sir.
That's what is it. Squaring of the shoulder. Right.
According to Rockwood classification, it's type 5, which is proximal migration of the lateral end of the clavicle, sir, along with corococlavicular and acromioclavicular joint
Is it
ligament disruption.
Is it vertical or horizontal instability?
X-ray is not
Sir,
a pure dislocation
sir,
or a fracture of the lateral end of the clavicle.
Not seen.
Not
it
It's
is
not dislocation only.
only
I
dislocation.
know X-ray, yeah.
X-ray should have been taken
Yes,
from the
yes.
shoulder.
That's what.
This is the regular X-ray even
Yeah.
for shoulder injury.
All- all
That
they'll
is-
take
that
shoulder.
is very essential. Otherwise, it is going out of focus.
Stress images.
Weight,
Want-
wrist weight cut.
You want to see the clavicle only, says what to do. That's not properly taken clavicle.
In the MRI, they have mentioned about a high-grade AC joint injury and partial supraspinatus tear and joint effusion, sir. But when we opened it, there is a complete coned and trapezoid tear, sir.
He has
When
come.
he was unable
the-
to do
he has
weight
come for
bearing and also
deformity or the pain
range
or
of
the-
movements were completely, not partially restricted, sir.
No pain. What's the occupation? Is important or not?
He is a worker in mess,
Manual labor.
sir,
Labor.
labor.
Mm. Mm.
He's able to abduct up to 90.
What's falling? Massage is not doing anything at all. I think it's completely.
He went
different.
for a massage, sir.
Okay, disability will not be that much. Unless it is very prominent up coming up, painful is there, then that's right. Surgery. Otherwise, not much. Even if you put the open reduction, do a pinning also. The pin, once you take off the pin, again the problem
It
comes.
will
There's headache there. The
dislodge.
best thing is, be careful to surgery for this.
Sir, for pain reduction only, sir.
Is it a functional disability or a cosmetic disability?
Functional disability.
No functional disability.
Functional disability ఉందని చెప్తున్నాను.
So what are the
అది చెప్పాలి. Is a functional disability, not a cosmetic. Cosmetic or functional గా చెప్పాలి. So it is a functional disability,
what have we decided?
not a cosmetic.
So
ఇట్టే చెప్పాలి. Mask ది. ఇట్టే చెప్పు.
So what are the options?
చెప్తాను సార్. Sir, first we can fix with KY fixation That's one method. If we remove it, there is a chance of dislodgement of the.
Okay.
Second thing is we can use a hook plate. 6, sir. That's sir. The other option could be use of hook plate. We can use a hook plate to stabilize it.
Okay.
You should have put the diagrammatic representation of that so far.
Hook.
Otherwise, by looking at this,
I think it's
you
in
will
there.
not have any idea about the.
So did you cut the lateral end of clavicle?
Yes, sir. Up to lateral 2 centimeters is excess.
What is the cause for pain in any sports? Intraoperative.
Maybe impingement of the supraspinatus.
Yes.
It can cause pain.
It's coming over that. It can be there.
Yes, sir. Morning, sir. So this is a case of left acromioclavicular joint disruption. It's a chronic case of. So we opened the site and we tried to reduce it, but it was unable to sit on its original position. And we cut the lateral end of the lateral 2 centimeters of the clavicle. And after exploring the corococlavicular ligaments, both of them were torn, sir. So, and the coracoacromion ligament is still intact. We tried to make a tunnel to the clavicle at the lateral end, and we restructured it with the tight loop. Coracoacromion ligaments.
So you put endo button.
Yes, sir. So that's the coracoacromion ligaments. Here.
Now new sutures have come. What is that? Like ACL.
Polyethylene suture material, sir.
Sutures have come, you automatically. It's called some name is there. For instead of putting a screw wherever in a distal ankle, diastasis, or here wrist, we have fiber tape sutures. So they're strong enough but flexible. They won't break. Expensive.
There's the lateral 2 centimeter excised part of the clavicle.
Is it reduced?
Yes, sir. And we applied an arm sling pouch after the surgery to prevent the disruption.
Sir, 14-year female with the osteochondroma of proximal tibia of left legs. Yeah. She's complaining of pains on and off.
So 14-year-old.
Yes.
Pain is the symptom. This is your short case for your examination. You should be thorough. So when do you get the pain? You think it's an osteochondroma?
Yes.
When do you get the pain? What are the causes for the pain in osteochondroma?
Bursitis.
Common is bursitis. What bursa is it? What do you call that? Adventitious bursitis. That's the commonest cause. Very good. Commonest cause of pain.
Yes.
Okay. What else?
Name nerve compression.
Compression of pessants.
Take your mask off. You can hear.
As it is a proximal and medial.
Is there any nerve there?
Saphenous.
Okay, in this case, saphenous nerve will be the subcutaneous. So, any pressure on the neurovascular bundle can cause pain. One of the causes. Yes, what else?
Pessants and attachment.
No, pain here. Pain, causes of pain in osteochondroma.
Neurovascular.
You said bursitis, adventitious bursitis, pressure on the neurovascular bundle. What else?
Malignancy.
Malignant transformation, yes. What are the chances of malignant transformation? Incidence?
Solitary 1%.
1%.
Multiple and 5 to 10%.
Okay. Yeah. What else? What else can cause? What do you see more people coming to you in casualty with the pain?
Fracture.
Fracture. It can fracture. Sessile or pedunculated get fractured?
Pedunculated.
Pedunculated. Okay. Anything else for the pain? Any cause? Okay. So 14, go back. Growth plate is not closed.
Yes, sir.
Yes.
Female, okay. Very unlikely. She may not be 14. Generally 14, what do you think? 14, 16, maybe, yes, okay. Maybe. Growth plate is a bit more open than usual for a 14-year-old girl. Okay.
We have done extra periosteal excision of osteochondroma, sir.
So what excision?
Extra periosteal.
Extra periosteal means?
With periosteal. With
You're
periosteum.
taking the periosteum along with.
Yes.
So why do you do that?
Recurrence.
To prevent it.
So you take along the periosteum, it will.
Yes.
What is osteochondroma?
Cartilage capped bony growth, sir, with along with the medullary cavity continuation of medullary. Yes.
Yes. Is it a normal bone or abnormal bone?
Normal bone.
Then why do you say tumor?
Extra growth, sir.
The growth is. So it's a normal bone growing in an abnormal site or abnormal way. So it has got, what is that? Everything. So the medullary cavity will be continuous with it. Okay. So when you say the X-ray, can you assess the size? Because it's a very common thing and you should know everything.
Clinical.
When you look at the X-ray, can you assess the size looking on the X-ray or clinically? Okay, clinically. If you see, what would be the size of the what is the swelling? Will it correspond to the X-ray?
On X-ray it will be smaller.
Smaller, yes. You know everything, but you're not talking. Why it's smaller?
Cartilage.
But there is a cartilaginous cap. And what happens in malignancy? The cartilaginous cap thickness will be
Decreased, thin.
You exercise a bit more than required, or you've taken most of the cortex as well. It's not extra periosteal, it's extra cortical excision. Gone deep. What is the complication of this? What will happen?
Fracture.
Fracture can happen, so you should protect her. Who did this?
Jerome.
Okay, go on.
In the circular fashion in 360 degrees, if 3 cortices are well maintained, less likelihood of the fracture. If it is disturbing more than 1/3, then it is a risk. Okay.
Good morning, sir. The case,
For
discussion.
discussion. Yeah. SI joint infection.
The 13 years female came to the OP, sir, with complaints of pain and swelling since 1 year in the left gluteal region. Diagnosed as gluteal abscess and done treatment by aspiration, sir, by general surgeon. Swelling not relieved and symptoms recurred, sir, again. The complaints of pus discharge in 6 months. Treated by regular medical management elsewhere. Patient referred to our department 3 weeks ago, sir. No history of fever. Non-healing ulcer, non-healing wound, sir. Pus discharges, foul smell. Sinus tracts, with no bony spicules coming from that.
Describe the sinus. What color and all those things,
There is a wound, sir, opening wound. Left at the left gluteal region with the surroundings normal. Above the gluteal. Sacral.
Sacroiliac.
What would be? You have got.
With surroundings normal, sir. Local rise of temperature presence. No, yes. Around, no, around the,
There is a
no,
copious purulent discharge.
purulent discharge.
Copious purulent discharge. And is it adherent to the underlying bone?
Yes, sir.
Puckered?
Sinus tract. Yes, sir. No, sir.
Okay. So what is the got? So what is the difference like?
Maybe pilonodal sinus is
Pilonidal sinus is a midline.
for
It is in the midline.
Child, some swelling like this.
There is a frank pus,
pus discharge.
yellowish pus. Chronicity means bone must have been involved. Sacrum is a subcutaneous bone. And it is puckered.
Yes, sir. Yes, sir. There is a deep tenderness. And the
Clinical SI joint tests.
You know what is?
SI joint tests.
Anybody?
flexion.
Krishna?
Flexion.
How do you test like that? Compression test.
Distraction. Distraction is more reliable than compression. Then
And?
Fabers.
Fibers.
Active? Active SLR. It is normal.
And you have to do the Faber-Patrick test. First to the hip, next to the flexion, abduction, external.
Investigation.
Investigation, sir. The ESR is elevated, sir. We have done AFB to rule out tuberculosis. Negative. CB natal is also negative, sir. The pus for culture sensitivity it came Staphylococcus aureus. And we send biopsy of the tissue, sir. Granulation tissue with bones, spicules not present in the specimen.
So you have to rule out any chronic infection.
Yes.
Isn't it? So what are the chronic infections, bony infections?
Osteomyelitis.
What organism? Chronic.
Staph aureus.
TB also, of course.
TB.
Can be fungal, chronic, secondary fungal infection. Can be rare chronicity. So it is.
Before the blood investigation is X-ray and imaging. That is the first one to be kept, not the blood investigation.
Okay.
The X-ray.
Can you see where is the osteomyelitis? Describe the extent.
The joint margins are eroded. There is surrounding sclerosis. So in presence of sclerosis, we thought that it might have been a pyogenic bacteria. If it is a grossly porotic with erosion, tuberculosis is a first possibility. But a significant amount of sclerosis is there. And of course, AFB may not be positive. You may not get a bacterium there, all necrotic material.
Secondary.
Yeah, quite possible, yeah. Now she has been on antibiotic.
Antibiotic, yes.
What was the antibiotic given?
Linezolid 600
according to the
mg.
sensitivity. Started on linezolid and clindamycin. But still there is
done, sir.
Still there is active
pus discharge since 3 weeks.
No, not much of improvement. Now how to proceed?
What do you want to do? Pus anywhere in the body, what should you do?
Antibiotics and curettage.
Remove the pus.
Curettage.
Antibiotics only help if there is no dead material inside. You must, of course, yes, that will be, but you must debride it, curettage, and get tissues. Pus, fluid sometimes may not isolate TB, any chronic infection, especially in the rural population. Unusual site is tuberculosis. So you must send tissue from inside, deep inside tissue, for microscopy histology as well as TB culture. I think it needs debridement. Oh, yeah. But needs, we may not go up to the SI John, but thorough debridement and washout. Then it would.
MRA, they had evidence of chronic infective arthritis involving the left sacroiliac joint. A short tract is seen extending.
Did you get MRI spine?
MRI hips.
You have to rule out any TB of the spine. Okay, gone. What? So, what MRI says?
A short tract is seen extending from the iliac aspect of the joint into the posterior superior iliac bone, breaching the cortex and tracking beneath the gluteus maximus muscle, suggestive of sinus tract. Okay. Left iliopsoas also, there is swelling.
There is collection in there, so probably you must. 7 centimeters is significant. So, might go up to the, I think, whatever level, you may have to go up to the joint. Spinal.
Yes, sir.
So how to make out the sacroiliacs on the anterior side? Iliac fossa only. Press underneath that, that's called a mere point is there, right?
I think probably debridement, you must get
Spine X, yeah.
Chest X-ray, physician opinion, screen for TB elsewhere, primary focus. And of course you have to
send all the curated material for biopsy as well as for culture.
Spine, nothing is there, no? Spine, nothing was there.
Clinically, no.
Except taken. Yeah.
But sacroiliac is one of the commonest joints to get infected by tuberculosis. Now, right now, it appears to be right now.
If it is TB means you don't have to debride all the way through.
Yeah, right, start.
So they
drugs.
found very helpful.
Yeah.
But if it is biogenic,
now,
then
to control the infection, just curettage is adequate, or any local antibiotic according to the sensitivity is going to.
Probably once you clean it out, good vascular area, and there is no implant inside. No implant inside, so probably not IV antibiotics.
Open the joint posteriorly, sir. Little more extension and then see, and let it out. Yeah, and keep it open. Yeah.
And then wait and watch.
Right.
If it is negative for TB.
Right.
Suppose, what about the empirical? Suppose if it is
You can
not
start.
respond, even after that.
I think you should
Empirical treatment.
probably
Theoretically, but
Yes.
practically.
Yes, you can start. Nothing happens. Many times you do it. Right.
If it is not responding for
Other
this
things.
treatment,
Yeah.
what we have been
That's what
suggesting.
you have to do. Yeah. TB regime has to start it. TB regime have to start it, know whatever it is.
Now itself.
Nothing happened. Yeah, nothing wrong in doing it. No, there's no nothing. There's no legal in the daily. We can start empirical. You think its treatment is there.
Good morning, sir.
Right.
Today my general topic is clinical guidelines.
चले गए ना?
ఇది మన డిస్కషన్ మోర్ ఇంపార్టెంట్ ఆ కేసుకి ఇది అందుకని
Clinical guidelines in the management of frozen shoulder and updates, sir. It's taken from Indian Journal of Orthopedics in February 2021 from Department of Orthopedics, Kasturba Medical College, ODP. Introduction: frozen shoulder, also called primary idiopathic stiff shoulder. No, sir. Yes. Frozen shoulder, also called primary idiopathic stiff shoulder. International Society of Arthroscopy, Knee Surgery and Sports Medicine recommends using the term frozen shoulder instead of adhesive capsulitis, since there are no adhesions in the joint. Frozen shoulder occurs without trauma or specific underlying disease, although conditions like diabetes or thyroid disease may be associated. In contrast, secondary shoulder stiffness results from identifiable causes like trauma or inflammation. Frozen shoulder affect 2 to 5% of population, more commonly men, typically ages between 40 to 60 years. About 20% of cases affect the opposite shoulder lateral, and 14% may simultaneously have bilateral involvement. Associated condition, primary frozen shoulder is idiopathic but is commonly associated with diabetes mellitus. Clinical features, the pain is gradual without prior trauma, infection or inflammation. Clinical guidelines in the management of frozen shoulder and updates. Treatment, conservative treatment of frozen shoulder is successful in 90% patients. Only a few require operative intervention in the form of manipulation under anesthesia or arthroscopic capsular release.
Some cases spontaneously resolve at the end of 6 months to 1 year, but don't keep hope on that and leave it for natural fate. So some of them, in spite of a very badly frozen shoulder, they get spontaneously resolved even without any treatment. It gets resolved. That is an important point to be learnt. Yes.
NSAIDs and other analgesics. NSAIDs remain one of the most common medical intervention in treating frozen shoulder. A short course of 2 to 3 weeks have given. However, course of NSAID does not alter course of the frozen shoulder, but enables the patient to carry out their daily living activities of daily living in a more relaxed fashion and perform physiotherapy with ease. Corticosteroid. Apart from NSAID, steroids are the second most commonly used drugs in the treatment of frozen shoulder. Both oral steroid and local steroid injections are widely used. This is a summary of various debatable parameters regarding injectable steroids. Yes. Sir, intra-articular, subacromial and rotator interval. Intra-articular, subacromial and rotator interval के पास. High dose 40 mg, low dose 20 mg or very low dose 10 mg steroid. There is no difference between 40 and 20 mg. 10 mg is less effective than 40 mg, sir. Single versus multiple injections. Multiple are no better than single injection in improving clinical outcome. Site intra-articular versus subacromial and rotator interval, sir. There is no overall significant difference. Pain scores better in intra-articular groups. Subacromial injection result in lesser fluctuation. Triamcinolone and methylprednisolone. Triamcinolone gave superior result in resistant cases and diabetes compared to methylprednisolone. Triamcinolone group had better pain score and range of motions. With or without imaging, there is added benefit of image guided injections without over blind injection in improving pain and ROM. However, needs further evaluation. Hydrodilatation, sir. In late freezing or early frozen stage, hydrodilatation of the glenohumeral joint using saline, steroid or local anesthetic agent is supposed to distend the capsule by breaking the early intracapsular fibrosis, which helps in improving range of motion. Calcitonin decreases systemic inflammatory response and stimulates the release of endorphins. Young et al. Confirmed the addition of salmon calcitonin in biopsy tissues from frozen shoulder improves mRNA expression of the fibrosis related molecules and decrease the enhanced cell substrate adhesion ability of the frozen shoulder. Extracorporeal shock wave therapy, it is and randomized control trial with 40 patients shows significantly improvement of function and ROM without adverse events. A review of 19 trials in 1,249 patients also reported no major side effects. It is a safe alternative for patients with uncontrolled diabetes or when steroids are contraindicated.
So what you are using in shockwave therapy? What you are using? You are using Faraday current, galvanic current. Shockwave means what? Shockwave what? Galvanic or Faraday. There is something called pulsed magnetic therapy. That is also coming up. It's also giving good results. Pulsed magnetic therapy. It's outdated. Shockwave therapy is outdated.
Acupuncture, though few centers have tried using acupuncture in the treatment of frozen shoulder and reported reasonable relief in pain and improved forward flexion. Nerve block, several authors reported that single or multiple injections to block suprascapular nerve in the treatment of frozen shoulder result in improved pain score and ROM. Surgical technique. Physiotherapy.
Regular ROM exercises break the additions. You are not mentioned.
Next.
It's not given.
It's given.
Manipulation and
Said there.
the operative
Manipulation is not there. Can you manipulate the G or not?
Yes.
Not a treatment.
It's my operative.
They have not mentioned that.
Manipulation is not surgery. Manipulation is
Manipulation.
technique.
Breaking between
Adhesion, adhesive capsulitis, you are breaking the adhesion.
instruments way breaking without that it is environment is looking like surgery. Surgical breaking.
Operative management, sir. Breaking operative management. Yes, go.
Figure 1 shows manipulation underneath of left shoulder while arm being taken in flexion, abduction and external rotation in 90 degrees abduction. During abduction beyond 90, head of the humerus is supported with a fist of assistant in axilla to prevent inferior subluxation of head while treating of inferior capsule. During external rotation movement in 90 degrees abduction, the scapula is stabilized by the assistant's hand over the scapula. Figure 2 shows manipulation under anesthesia of left shoulder while arm is taken in internal rotation in 90 degrees abduction, cross chest adduction and external rotation with arm by the side of chest. During internal rotation movement in 90 degrees abduction, the scapula is stabilized by the assistant's hand over the scapula.
What happens here? Get movement next day. Next day get maximum movement you get all the weight.
Next day they will get somewhat movement.
What is that protocol they have followed?
చెప్పమ్మా గట్టిగా చెప్పమ్మా ఏంటి ఏంటది ఫుల్ ఫామ్
Flexion, extension, abduction, adduction and rotation.
internal rotation ultimate external rotation followed by internal rotation. See ultimately it has go to to break the adhesive capsulitis. So what is this problem of MUA, manipulation under anesthesia, idiopathic fractures can happen.
Fractures,
You do
dislocation,
something like that, you can fracture.
iatrogenic.
Iatrogenic surgeon. What is iatrogenic? Surgeon induced fractures. So that can be one of the problems.
If the bones are very grossly porotic in prolonged chronic cases, they are grossly porotic. This complication is highly likely.
Anyway,
The manipulation should not be forcible. It should be very, very gentle. We should spend 15 minutes of the manipulation. Means some of the physiotherapists, by over enthusiastic physiotherapy, they have broken the surgical nerves or even the shaft. Shaft rotational injury causes shaft spiral fractures. I have seen cases.
This is the summary of various contentious parameters regarding manipulation under anesthesia, such as timings with or without steroid injection, comparison with other conservative methods, comparing two commonly used steroid molecules, and outcome in diabetes versus non-diabetic frozen shoulders. In timing of manipulation under anesthesia, delayed between 6 to 8 months while shoulder is in late frozen phase. Early manipulation under anesthesia is freezing or early frozen phase could result in aggravation of symptoms. With or without intraarticular steroid injection, there is no difference. Hence, authors recommended that addition of steroid is of no use. Comparison with other conservative methods such as therapeutic exercise, steroids, and distension, there is no difference. Outcome of MUA in diabetes versus controls. Diabetes have poorer outcome and there is no difference. 36% of diabetics may require repeat MUA compared to 15% controls, and 38% risk of repeat MUA in diabetes compared to 18% as a group. The arthroscopic capsular release in frozen shoulder is diagnostic and surgical approach. Entry is taken by posterior portal. If difficulty in entry due to tight capsule, you should avoid forcible trocar insertion and go for lateral entry for very tight capsules. And intra-articular findings include rotator interval contracted and inflamed biceps tendon, often inflamed synovitis. Common over capsule under supraspinatus and infraspinatus. This is orthos.
What is the lighthouse of the shoulder joint? What is called as the lighthouse of the shoulder joint in arthroscopic procedure? Long head of the biceps.
Surgical technique. Anterior release use radio frequency device. The release include rotator interval, coracohumeral ligament, medial glenohumeral ligament, and anterior capsule. Sir. Posterior inferior release shift scope to anterior portal. Posterior capsule release till posterior inferior corner. Inferior capsule not released surgically. Gentle manipulation under anesthesia to avoid axillary nerve injury. Subacromial debridement. The debride adhesions inflamed bursa via lateral portal. Recheck and release coracohumeral ligament adhesions on subscapularis, which improve external rotation where subscapularis release to base of coracoid. Final steps confirm free shoulder motion in all directions. Injection 40 mg triamcinolone and 10 ml of 0.25% bupivacaine. Steroid injection is optional. It is evidence mixed.
But he is not saying where to give injection. How to give, suppose the patient is wrong. Injection you want to give. Which side you want to select and give?
Anterior, posterior, lateral. Site of injection. Intra-articular injection.
Oh, that can be anywhere. Intramuscular can be given.
No.
Higher can be given. It will same effect into that. But locally you want to give injection. Where is the point? Select the joint.
Point of selection.
Posterior.
Posterior. What anterior? Which is easy. Which is landmark? Which is the landmark to make out this joint?
For all joints.
He said lighthouse is only long head. Lighthouse also only coracoid also lighthouse coracoid. Coracoid process there, palpate it, just lateral to that, then joint only. That should be there. Without knowing how to give injection.
Conclusion: evaluate for comorbidities, especially diabetes and thyroid dysfunction. Ultrasound is a reliable, less expensive first-line diagnostic tool over MRI. Conservative treatment, NSAID, steroids, and structured physiotherapy is effective in most cases and should be continued for 6 to 9 months before considering invasive options. Among invasive options, arthroscopic capsular release is preferred over manipulation under anesthesia due to fewer complications. Post-op care, early sustained physiotherapy and good pain control are essential, and diabetics generally have poorer functional outcomes than non-diabetics.
What are the other conditions that causes frozen shoulder? One is diabetes, other one is thyroid. Any other causes? Rheumatoid arthritis. Any other causes? Asthmatics. Those people osteomate, they continue to take the steroid injections. So that is also avian. That avian also, avian of the,
What is hand shoulder syndrome?
yeah, avian of the head of the
Hand shoulder syndrome.
humerus also
Sir.
described. Sometimes it can be Kerisika. What is Kerisika? Kerisika, dry tuberculosis of the shoulder joint.
So why did you choose that?
This is a common condition.
No condition. You have treated with all these manipulations, injections. All this.
No, no, PRP, what is the role of PRP?
No, no.
PRP, no role. PRP, role అనేది మనైనా PRP. No, no, PRP knee, PRP all. PRP all, PRP knee, both are different. PRP all, PRP knee, both are different. Ramude, Jubilee, all different.
But did you see any time injection being here? Man patient have done here. What else you have done here? You said there are so many cases I have seen now, right? But
Yes.
what have you seen we treated here? How? Only anesthetic, right? That's not. Physiotherapy?
Yes.
Okay, you have gone there and seen patient is improving or not. Physio.
Yes.
You know, you have seen improvement is there, physio.
Yes, sir.
So injection, did you give?
In Apollo, they gave.
Here I am asking, not a question. Last recall, what else you have done here? Here. What else you have tried here? Man patient have tried? No. So now what do you want to advise now to us? Go for manipulation or give injections anywhere you want to give or what you have to give?
Physiotherapy first, sir.
This is what? What is range of movement? Certain points are there to be given. Man patient to be given.
Range of movements.
Which is most economical and most functional method? Surgical, non-surgical? Conclusion.
Non-surgical.
Non-surgical is better procedure than the surgical. What is the non-surgical?
Physiotherapy.
Physiotherapy. అదే చెప్పిన సరి చెప్పిన కుటుంబం మొత్తం
The article you have sent me. Different. What is it? That was good. Really. Also that
TBR.
Management. Fundamental
Sridhar sir change करो बोले.